Good day, friends of Buzzy. I am euphoric this week for a number of reasons. The reason that I'm most euphoric is that today we have a guest on our show, Dr. Jody Thomas, who has been a friend and colleague and supporter for so long. When she was at Stanford, she founded a center for pediatric pain and contacted us to get some buzzies and also to talk about putting Lady Buzz in a video about how kids can control their own pain. And so if you've ever met somebody where it's like plasma arcs going back and forth between your brain and you just get each other like you are two gloves from the same pair, that's me and Jody. So this week she has been on, I think, every major news channel talking about needle fear. So we're going to have her on today and ask a bunch of questions. And as always, if you want to put questions in the chat, please feel free to do so. We'll do our best to see them and answer them. And without further ado, I am just going to bring in our guest. Hello, Jody. How are you?
Oh, I'm good. That's a heck of an intro. So thank you so much. I would like you to follow me around to do all my intros.
I know with palm fronds, actually. How did you decide to leave Stanford? I know you still teach there sometimes, like this week, but how did you decide to go and start a nonprofit foundation for needle pain and fear?
Well, it's an excellent question.
I'm sure it's a standard question. They're going to get harder, but that's still kind of a big risky decision to make.
It did. And just to be clear, I love my time at Stanford, and so love that I still get the honor of having some ties and doing some teaching and supervision, which I absolutely love. But really, starting the foundation was about kind of trying to bring what we were doing there and what you advocate for so much to kind of everyone. So in a lot of ways, it was about sort of healthcare equity and access. And also the ability, so a lot of our mission is around kind of using technology and design in order to reach people. How do we create kind of this great health behavior change and give people what they need to empower themselves, particularly around pain management and like medical anxiety. And so I was lucky enough to be kind of marinating in the Silicon Valley and had a lot of these lovely tech geek friends who knew all the things. And how could we kind of come together to bring sort of cutting edge medical science with good technology and design to do what we can to help everyone.
Now, why did you pick that area? There's a lot of places where there's suffering. So why did you pick pain and needle pain in particular as your suffering focus to fix?
Well, in a lot of it, so our focus in the foundation is on kind of all pain, but our focus started on needle because in some ways that is, it's kind of the most straightforward, right? As you well know, that there's so much evidence about how we can make this better. We're just simply not doing it. And that is part of the mission, is how do we kind of let people know what should be done so it actually gets done. But needle pain really came about is that, I've been working, my specialization as a clinical psychologist is in medical illness and trauma. And I spent 25 years working in this field. And I got to tell you that even as we work with families with cancer, with HIV, with transplant families, the day-to-day thing that causes them so much of the most distress is in fact procedures and pain. And I always think back to, I had this 27-year-old girl sitting on my couch because I see a lot of these young adults. My sort of joke is that I started the foundation because I was tired of playing cleanup and I wanted to play prevention. So this 27-year-old girl sitting on my couch who had survived a really severe bout with cancer in her teenage years and had survived that, but then had been paralyzed by anxiety and PTSD because of all the procedures she went through. And she just looked at me at one point and said, "Where were you when I was going through treatment?" And I was like, you know what? That's a really good question. And that really became that mission of how, as I tell people all the time, you don't need me, you need what I know.
Yeah. Oh, and yeah, exactly.
Can I get what I know and what so many people like me know, actually not magical, just me, but how do we get what we know helps into the hands of people when and where they need it? And that's really why we started here.
Yeah, Mark, it's so funny to me as an academic to come back to the fact that you can be right all day long, but if you don't have the marketing behind it, if you don't have the ability to, as a friend of mine says, to talk into their listen, to find out what's going to make a difference for them and then act on that. When I first started doing pain management studies, I swore I was never going to measure pain as an outcome because doctors don't care about pain. And so I was like, there's absolutely no reason for me to do a study to see whether or not pain is reduced, because that's not going to change the behavior of the people who are causing the problem. I mean, being a doctor, I'm full in there. But my first studies were doing spinal taps, lumbar punctures. And at the time I started, doctors weren't using topical anesthetics or any anesthetics on these little babies. And so the very first study I did, I wanted to show that if you did topical anesthetics, it would improve the outcomes, that you're more likely to have a successful clean tap. And they wouldn't let me do it because the institutional review board was like, there's no way they're not using anesthetic. That'd be inhuman. That'd be terrible. How could that possibly be? So my first study ended up being a survey to prove that people didn't use topical anesthetics for spinal taps. So, and then I proved that it did improve outcomes, and so now it's become standard. But it was definitely trying to persuade the right people and have the right marketing and have the right messaging to get through to the people that need to make the difference is absolutely
it's an art form, and it's really important and often really ignored by the medical community, which is inadvertently kind of shoots itself in its own foot that way. I mean, a lot of ways what we have is a marketing issue, but it's interesting you said, because my first version of my dissertation, which ended up being slightly different, was looking at teaching kids to use self-hypnosis for the management of pain and distress.
Oh, because Leora Kuttner is on your board.
Yes, around lumbar puncture. And it's interesting, it's the same thing of like convincing people to do that was really about, are we going to save you time? Are we going to save you procedural time? Are we going to save money on meds? Are we going to save money by not putting kids under? And so there really is that part of how can what we think should happen, who are you talking to and what matters to them, right?
Yeah. It's really been fascinating because like all doctors, I have this distrust of the stench of capitalism. And so it's been like, we've taken 12 years to get where we are, in part because what matters to the people who are telling doctors and nurses about Buzzy is that it has to make them a profit. And so if we don't have distributors, people don't hear about it unless there's people like you, but that's, that what are the odds of having someone decide to devote their career to the thing that we care about also? But that's been such an interesting thing, is to try to find out that making a device that's reusable and thus inexpensive compared to any other thing that's used in a hospital, by doing that, we've shot ourselves in the foot because you can't get hospital reps to distribute something that's reusable. It's been, and it's just like, it's shocking because everybody who has talked to us along the way is like, we'll invest if you make it disposable, or we'll carry you if you make it disposable. And so it's been this tension of how do you realize what is making a difference for the people that you need to help spread the word, and make it something that doesn't undermine what your goal is.
Yeah, that is.
This
is what makes me glad I'm a nonprofit.
No, it's
and I don't have to. This part.
No, it's been such an education, and there's just so much. I'm sure you feel the same thing. Once you're inside the system, there's so much that you want to fix. You're like,
absolutely. I mean, and that's exactly and it's one of the reasons why we have so many amazing people who volunteer their time and efforts for our board and our advisory board, because they also, like, people know that when we're sort of within an institutional framework, there's just limitations, and it's, they serve their purpose, but they also can get in the way. And so we have this glorious ability to do kind of whatever, right? We're not limited by this, and our whole goal is to share. as opposed to we're not trying to protect, a brand or keep things proprietary. It's really about how do we kind of help everyone. And so because of that, we get to really benefit from the amazing expertise of these people kind of all over the world who are willing to help us out. And so it's phenomenal because they're really they're definitely a big reason why we're able to do what we're supposed to do.
Yeah. I want to ask how you got your board, but one of the things that's ironic about our mission, and, because our mission is to eliminate unnecessary pain. And one of our tenets we have 5 values, and one of them is to conserve resources, is to be good stewards of resources. So that means that we don't use plastic, and we don't contain plastic packaging, and we don't have disposable items. But the interesting thing is that we would have been a nonprofit, except that in order to get funded by the National Institutes of Health, you have to make a for-profit company.
That is fascinating. I did not know that.
It is so the funding that I got to make Buzzy, and the funding I have now working on opioid reduction, is all because of a small business innovative research grant, and it has to be a for-profit company, and you can't switch.
Interesting.
But one thing we thought about is switching over. So this is a question for you. How do you know when you're done? So at what point will your goal be accomplished and your mission achieved?
I wish I could say that it'll happen in, I think, soon, but really overall goal, if we're going for, is what they call I know people say, okay, what's the big fat hairy goal, right? Like, what's that? And the big fat hairy goal is to transform the way that we think about kids in pain. And that is about, so one of the examples.
Transform from what to what?
Transform from seen as a necessary evil that we just have to suck it up and do, to things that can actively be managed, and that we are empowering, that we're really we are setting people on that course by letting kids and families know that there are things, whether that is chronic pain, that is acute pain, that is procedural pain, there are active things that they can do to manage and make that better, that they can have this power over their body.
Yeah.
Right now, it's not. That's not how people think about it, both providers and parents and kids. I mean, obviously, there are some people that do, but that's not general. Like, one of the things a big question that we got, that we still actually get less now in the pandemic when we can see the impact on so many things. But I remember sitting with some, potential donors, and literally so much of the question that comes up is like, why do we care? Like, what is
such a pet peeve? Such a pet peeve.
I care about this.
Need to grow up. It's just
and then it doesn't hurt that much. But one of the things, it's funny because they're like, when we explain how this benefits the child, the parent, the healthcare provider, public health, the healthcare system, like literally it's one of the few problems on the planet that if we solve it, everybody wins. And the people that would say, like, well, if that were true, then it would already be happening. And I was like, oh, if only. And so the example that I will use, and I said, okay, so like, well, if that's true, then we would clearly be doing it. What's the deal? And I said, well, okay, let me give you an example. To explain this, let's go back 3,500 years to the invention of the wheel. And then we're going to fast forward to the 1600s with the invention of the modern steamer trunk, although I think we can all agree we were carrying stuff around long before that. And then I like to show them a picture, we'll usually have a slide presentation, of the first patent for a wheeled suitcase, which was in 1973. And I was like, we put a man on the moon and invented computers 50 years before we decided to put together the 2 most basic inventions of humankind. And even when it was invented, and I believe you're old enough to remember this too, we were not carrying around wheeled suitcases in 1973. Turned out that took years because luggage companies would say, kind of the message we get about this, which is, people are fine, it's not a big deal, it's not that much of an issue, we're not going to make this. And it wasn't until Macy's ran an ad, it's very 70s, and thank you Google, I could find this, of this woman, like this very 70s looking woman, dragging her suitcase and then with her wheeled bag, like gliding through, did anyone start doing it. But it wasn't until that people were sitting in an airport and you saw like a wheeled bag go by and you're like, why am I dragging this sucker around?
Right.
Did people start to demand that every suitcase had wheels on it.
Yeah.
And so what I like to say is that I'll be done when good pain management is the wheeled bag of healthcare, where it doesn't even, we would never go buy a bag without wheels on it anymore. And that's what I want. I want it to not occur to people.
Yeah.
Not manage the pain of not only kids, but adults too.
Yeah. That's so interesting. So it's funny how we both have to get our analogies and have to get a way to make people care about it and realize it's a deal. Certainly, you've heard me. I will talk about the fact that until 1985, no one was traumatized between age 4 and 6 on a regular basis that was scheduled. You just didn't get government issued trauma if you were born before then, because you were getting all of your 6 shots before you were 2. And so you can't really understand what it's like. And so I'm still trying to figure out a way to make people without a phobia identify with a phobia. But the one thing I use, it's a car analogy like you, is I'll say, we didn't have cars until 1908, and we didn't realize we needed to mandate seatbelts to make them safe until the 70s. And so we haven't had hypodermic needles for that long, and we don't realize that there are unintended consequences and risks of them. And so we haven't gotten to the place where we fully have invested in making them safe for things that are natural consequences from the benefits of having them. So that doesn't make people identify with it, but I do think that it's quite easy to realize that, we've only had cell phones for a while, and we're starting to realize the dangers of these for kids. It takes a little while after you get the technology to understand the unintended consequences of the technology.
Well, and I think even the more benefit to that technology, the easier it is. And that's, I think, getting to people to the point, like you said, I think the seatbelt is a great one. Because you're like, look, we're not saying the answer to the fact that cars can be dangerous is in don't be in a car, right? It is, let's wear seatbelts. Let's make them safer.
Let's make them, yeah.
And that's the big message of, we're not saying don't ever use, like, we're never going to need a needle. Although, yes, like needleless vaccinations would be fantastic. But that truth of being like, yeah, we can do this better. That's okay. We can. It doesn't have, we don't need that negative side effect along with the benefit.
Yeah. So we differ in this. We've talked about this before, but one of the things that my research on needle fear showed was that the kids who got 1 shot every time didn't have needle fear 5 years later, that they became resilient. And then there's the analogies I use is, if you, for the first time you remember going camping, if you get stung by 5 wasps, you're never going camping again. But if you go camping and you get stung by 1 wasp, then people who are around you can support you to go, it's okay, shake it off, rub it, and you build resilience. So if you have a good time and then you get stung by a wasp the next time, you're like, oh, well, that's part of what happens, and that's okay, I can handle it. So I'm actually okay if we don't use pain control for the 4 to 6 year shots. If we help a kid learn how to do distraction, and if by breaking them up and just staggering them throughout that whole 6 year period, 4 to 6 year period, if we just stagger them, then we'll give people a little bit of resilience and teach it to them. So I'm actually okay, I suppose, with a little bit of pain that's preventable, if it is not overwhelming, and if it's something that is helpful, so that when they have hardships later or they have pain later, they've learned some ways to cope with it.
Well, I guess that's the thing. Like, do you consider, because I'm not sure we're that far apart on this, actually, because as what you consider pain management. Because I think teaching kids the skills of distraction and keeping them is pain management.
So that
piece, we also agree that if we can, and this is where, again, oh my goodness, logistics and of public health and things, like, I also, like, if we can get away with doing 1 poke instead of all of them, it's absolutely, I know the pushback, which is a reasonable pushback, is that the follow-up and the actual adherence to, vaccination schedules can get worse if we, don't have them.
Show me the study that's found that, because we haven't seen that. We've seen the people that divided up actually all got all their shots. I feel like as pediatricians, we feel like if we send a kid out into the world at age 18 with all their vaccines, then we think our job is done, and we don't care if, like you have on your website, if they're not accessing healthcare, if they're not getting insurance, because they aren't going to go to a doctor anyway.
Well, talk about something that needs more study, right? Because I think the parents who are sort of invested enough, I mean, I did this, I broke up my kid shots, they'd be like, they need 4 shots. I was like, not today.
Yeah.
Anti-vax. I'm like, no, I just am anti-traumatizing my kids. So we're not going to do that. I will happily come back. We'll make the follow-up appointment.
Yeah.
But I think the parents who have the luxury of being able to think about that much are also the ones who probably have the luxury of coming back. But I don't know what that would look like. And I think it's a really important question to be studying and asking, what would that look like in a more general population where you have, the single parent who's trying to do with 4 kids and can't take off, that taking off work to come to a pediatrician appointment.
Yeah.
So
well, yeah, I think the way it looks, looking to other countries. So give the vaccines in pharmacies. Give them in school. When I was in Thailand, I was actually vaccinating kids, and they stand up in school. And of course, as you know, kids in that age range, they do better if they see their peers or even someone younger who's doing well too. And so I think that we should spread where we give them, so it's not all conditioned to be associated with trauma going to a well child visit.
Yes.
I think that would be one real, but if we get to microneedles, then I think we're going to be great, because one of the studies that first was talking about anti-vax, they found it was Dan Salmon's 2005 study in pediatrics, and the least refused vaccine by parents who were vaccine skeptical, the least refused vaccine was polio, and at the time it was oral.
Yeah.
And it was oral, and it caused actual polio, and it was highly immunogenic, the things that they said they didn't like. But
yes.
But anyway, so I do think that's one of the wasted opportunities with COVID, is we could have been doing some really good studies to find out how to reduce needle fear that's there. Hopefully we'll get microneedles and we won't
done all those things, but
we've got a whole generation, as you know.
Yeah.
So let's talk a little bit about your board. How did you get people to be on your board? Is it a traditional nonprofit in that they do some financial support as well as outreach? Or tell me about putting your board together, because that's been a really hard thing for me in starting a company.
It is a challenge. I think we've been incredibly lucky. I like to joke that running a nonprofit is asking anyone you've ever known in your entire life for a favor.
Like running for a political position.
Yes. Hopefully with slightly more altruistic intentions, but yes, exactly. So we put together a board. Really, it's kind of, because this has been sort of an idea for years and things we've been talking about, that became a little easier, right? Like people were, and I think the attraction, I think we have to ask some of the board, but the attraction being that, we kind of came in, we very specifically put together people who had sort of a natural enthusiasm for what we were doing. I'll tell you, it's interesting, and I think speaks to how prevalent of an issue this is. Every single person who's almost ever been involved, whether a paid consultant or a contractor or whatever, they have a personal story to tell. They have, this is what happened to me when I was little. I don't want this to happen to other kids. This is what I have to deal with. I don't want this to happen. So I think there is this, we're very, very lucky that there's a personal attachment to the mission, which makes it better. And our board, we kind of come in, I think we've developed a really good kind of rapport and space where we want people to do, just kind of to do their thing. Right? That we kind of talk about what they can bring to the table, what they want to bring to the table, what they have the time to bring to the table. And really, I think setting up that communication, I've learned, has been really wonderful. And then we have both a board and our advisory board. And so our board, there's sort of the very technical, practical differences of, they have to show up to board meetings, and there's voting, and there's, sort of the rules of having a board in an incorporated thing. And so we have our, our executive committee and all of those things. And that requires, considerable time and a commitment of energy, because we have very much at this point a working board. We're not quite at that point where we can hire all the people. So we depend a lot on kind of the volunteer hours of our supporters. And then our advisory board allows us, is kind of, we get to peak from their expertise and their time and energy, but with less commitment for them. So we kind of have several board members who started out as advisory board members to kind of dip their toe in the water, so to speak, kind of figure out what it was like for them to be involved, and then decide whether or not they wanted to kind of commit more time and energy to that. So it was a piece of advice that was given to me early on, the concept of an advisory board. So we kind of keep our board kind of on the smaller and tight, to be able to really to be able to kind of make sure that we're respecting everyone's time and still getting what we done. And then the advisory board allows us to kind of still garner people's support without them having to commit forever to us.
So it sounds like I'm going to take this moment to let you know that we're going to reward you with the Buzzy Bravery Honor Roll. Hear ye, hear ye. It's officially known, and it seems like you've had to have a lot of patience. So, so I'm going to put the patience.
Honor. That is it.
There you go.
Thank you so much.
And it also sounds like you probably had a lot of, you've benefited with a lot of helpers. And so be a helper to get people who are helpers to help. So I'm going to give you the helper one as well. But so we haven't really gotten into you personally. Did you move to Colorado because you like to do hiking and skiing? What does Jody Thomas do for fun?
I do love to do hiking and skiing. We are kind of an outdoorsy fam. So I ski very poorly, to note, but I do ski. The goal now that we live here, so we moved here 5 years ago when my kids were little. So now my kids are very good skiers and rock climbers and good little Coloradans that way. And yeah,
you're a cool mom then.
we try. Oh, look, I'm racking up the.
I'm
feeling good about myself.
It's going to go well for you today. I'm pretty sure it's going to go well.
I'm feeling good about this. So yeah, we moved to Colorado from the Bay Area. Just to really, Bay Area is kind of an expensive place to live. I'm sure you've heard, and wanted to be able to be in a place where we just had the time and space and energy to, most of our existence happens within about 1.5 miles of our house. The kids' school. I work from home a lot. My office is actually about 3 minutes away from my house, so it just gave us a really good lifestyle after spending a lot of time in cars and traffic in the Bay Area.
So you have been on TV a lot this week. What do you like most and least about being interviewed on TV?
I love being able to get the word out and talk about what I'm passionate about, and that so many in the field, like yourself, have been trying to do for years. And we just love trying to grab that opportunity to get this out. And especially right now when there's this, I hope, is the most interest we'll have over the course of our life, just because the pandemic. So we're just super grateful for the opportunity to kind of take this moment where there's a focus because of the pandemic and vaccine rollout, to get the message in there and shove it in as much as we can. What I like least is having zero control over what they actually decide to show, or edit, or message. And so again, like with most things, we just do the best we can and hope for the best.
Yeah. No, I feel the same. I mean, I think of everything that I would like people to learn about this from the pandemic. It's how to tense their stomach muscles to not faint, and lift a knee up if they get lightheaded, and how to distract themselves. And so I get so disappointed when the pain, fear, focus concept and the aspect of effective distraction that anybody can do, that gets cut off. So
yeah, I share that with you, and I also share that concept of the fact that, we launched, of course, this, our focus has traditionally been on kids and families, but then when the pandemic hit, we launched the Hack the Vax initiative, which is focused towards adults and their needle fear. But one of the phrases we like to say is, whether you're just not a fan or they strike fear in your heart, this is helpful. And I really don't love the concept of people like, oh, well, you have to be terrified of something to do something to make it better. Instead of the very concept of like, guys, we should all be learning this, like when little kids fall, we train parents to sit there and with my own littles and they would start crying. I'm like, okay, so it is it the ouch or the scared?
Right. That's a really good way to get them to get in touch with their
just to think of like, oh, there's two things going on here, right? Like I'm scared because I just fell and that was scary to fall in the middle of doing the things. And I don't know, maybe my knee hurts, maybe it doesn't.
Right. I'm not, yeah.
Checking in with themselves.
And even with adults, I think it's amazing to me how conflated people are about pain and an irrational panic formed before you were capable of logic. You know, it's just like, no, adults with needle fear know that it doesn't hurt. And maybe 10% of them will be benefited by the control of having something to make it hurt less. But we know, I mean, twice as many are going to be benefited by having control over not fainting. And not everybody who faints is fearful. And it's just the fact that there's so many different components and you can't make it one size fits all. You just need to give everybody some aspects of what they need. You know, here's a bunch of resources, pick which is the issue for you. And then you're not alone. And we've got that. Do you hear that all the time? We hear so many people say, I thought I was the only one. I have felt so alone.
It is the number one thing that we hear. It's really behind all this massive effort to get out. People like, I don't know anyone else with this issue. And I'm like, unless you're a hermit in the woods, that is statistically impossible.
Right.
You do. We just don't like to talk about it. And we want to bring that out. And it's funny, because what I was saying before, one of the things that, and on our sort of list of missions and goals as we're moving on, and when I train providers all the time, is about teaching them really the biopsychosocial model of pain, which is academically exactly where it's at. This is what it is what the pain experience is about, but people don't think about that. You know, not that long ago, I was in a hospital consulting and I was sitting there with probably 50 residents in a room. And I asked them two questions. I said, okay, so this data would say that you guys only get about 9 to 11 hours of training in pain over the course of your medical career. Does anyone in here think that they got more than that? No hands went up. And then I said, okay, cool. And I said, what is the number one reason? We're in an inpatient hospital at this point. The number one reason you're going to get called to a bedside?
Pain.
Pain.
Number one reason they come to the emergency room? Pain.
Pain. Yeah. Number one reason you're going to show up at the doctor? Pain.
Yeah.
Exactly. All the things, right? And so when we're sitting there, and I also asked them, I said, who here could explain to me what the biopsychosocial model of pain is? And one hand went up, and that was attending. And being able to explain that, you know, this morning, as I mentioned, I was giving a talk at an autism conference for parents. And when I bring this up, and I literally have a pretty simplified explanation, and we go over the factors that go into the pain experience under each one, it's sort of amazing to have people kind of be like, oh my gosh.
Yeah.
Okay. Because then we have something to do about each one, right? Then we have an action to take.
I love this is not original. I got it off the Montreal amazing, the McGill website for pain management and neuroscience. Yeah. But pain is the brain's opinion of how safe it is. Yeah. And so it is not happening in the periphery. It's all happening inside the brain. And that understanding of how meaning changes pain and fear changes pain and attention changes pain, and all of it comes together and comes from different places. And so you can really intervene in lots of different places, but you have to make your brain feel like it's safe.
Yeah.
And so that is the foundation. I mean, all the stuff that Rebecca Pillay and Chambers and Megan McMurtry are doing, looking at how kids are reacting to their parents' signals. It's because, you know, if your brain
is safe or not, look at mom and tell me. Yeah.
You're not going to feel safe. But one thing was fascinating about our study with the needle fear study was that by the time they were teenagers, and we asked them how worried they were about their kids' shots, the parents were like way over here on the not worried, they're a wiener and I am embarrassed. And kids were way over here on, I'm telling you, this is a big deal to me. And in fact, one of the most predictive things of how much pain they rated was how much pain they said they thought it was going to be. Because the teenagers were like, see, I told you this is a big deal and you're not listening to me. And so it was just
an argument for the need for validation. I mean, it really is. And this is what we talk to our teams all the time. I'm like, yeah, this is a thing and it's a big thing. And it's a very natural and normal, and it's not a manipulative even response to
exactly. Yeah.
It is a safety issue. It's one when we train providers, and I've tried to get this idea in all sorts of different ways that, and having run the program, our program, we treated kids with CRPS, which of course is an exquisitely painful disease, and it requires incredibly painful desensitization.
Yeah.
It legitimately incredibly hurts. And so the judgment call that we train them and that they need to learn is, what is pain that is telling me something important that I need to pay attention to? Like, my body is being damaged. This is the most natural instinct we have as humans. And thank God that's how we've survived as a species.
Yeah.
But we have to have a reason to ignore a pain signal. We have to understand, and it's that safety issue you're talking about. How do I assess my safety in the presence of pain?
Yeah.
How do I know that's a signal I need to attend to, or I am allowed to ignore?
That's one. So I don't know if you know that, you probably do. I got so frustrated by people not listening to me about needle fear and going like, oh yeah, it's because you're selling Buzzy, that I decided to just leave needle fear entirely and go into opioid management and reduction because because my feelings were hurt and it was frustrating.
Exhausting. Yeah.
And then I got dragged back in because of the pandemic, and it's like, no, seriously, I know stuff. But one of the things that we made was a whole bunch of surgical activity, pre-surgery activity kits, and so part of it is, just to your point, asking the doctors, what day is pain going to be highest? Because post-op pain, if they know that it's actually day 3 where people complain of pain the most, then on day 3 when it's hurting more, they're not anxious and they're not as worried, and they know those signals are not signals that they need to worry about. But we've made a whole bunch of schedules for, here's your distraction schedule. What are you going to do from a mind-body perspective? What are you going to do from an entertainment perspective? What are you going to do from a physical, have all these things ready beforehand so that you've always got something to do while you're waiting for time to do what it does after surgery, so that you can avoid opioids and have a plan.
Yeah. And this is where that use of language to frame that experience becomes so important in the setting of expectations. Like, and that gives that attention to the attentional aspect of pain, because if we have to be hypervigilant, that is.
Oh, yeah. I would always, by the way, I think that it's really brave to have started something. So I'm just, while we're still apropos of nothing.
Well, do you want to hear a kind of crazy story that I will sometimes tell? And this is that I like you about, that I'll sometimes tell about safety and how do we have to assess safety in order to dissociate from pain. Mm-hmm. So one of the things I'm not sure if you actually know this. This is funny. So I teach hypnosis. So I'm the faculty of the National Pediatric Hypnosis Training Institute, and so I've done that, and my actually dissertation was on teaching kids with sickle cell anemia to use self-hypnosis. But so, I've learned a thing or two myself. So when I had both of my kids, for whatever, a long and complicated explanation we don't need to get into.
You do hypnobirth?
Well, here's the deal. So I have some genetic disorders that make having a baby kind of tough. And so I had to end up having 2 emergency C-sections, basically without anesthesia, because part of that genetics is an issue with anesthesia and our ability to do it. And so, having 2 huge surgeries without anesthesia. And we didn't know going into the first one how much we could do or not. And I was on, every bit of monitoring you possibly could, and the arterial lines and the whole thing. And the first one, here's the thing, no one in that room, I joke that I had like the most expensive birth of all time, because we had like 4 anesthesiologists and my high risk and my OB and the pediatric team and the NICU team and everyone and their mother and on the birth in order to keep me safe and the baby safe. But we didn't know how it was going to go, right? No one knew. It was like, we're just going to go see what happens. We're going to try. They would put in like a tiny, 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 tiny bit of anesthesia and then basically wait 10 minutes to see if it destabilized me. And then we do this hours. And it turns out the answer to that was not much, like barely anything before we had to do the birth. But at that time, people were like, well, why didn't you just use hypnosis? Why didn't you just dissociate? And I said, here's the deal. Any pain signals happening then had important information in them. We needed to know. No one in that room knew how this was going to go. So if I had pain that wasn't expected and not there, that was really important in order to keep me safe and the baby safe. And the anesthesiologist, who I love and literally bought a case of wine for after this, he would look at me every few minutes, and when we had to do the cutting, and he would look at me and say, "You're okay, the baby's okay." And I'd be like, "It's okay, it's okay, it's okay, it's okay, it's okay, it's okay, it's okay." And I'd look at him and he's like, "You're okay, baby's okay. It's okay, it's okay." But again, that permission of safety. He was telling me that I was safe.
Yeah.
And so it was so different. So we got baby all fine, all good, back to the ICU, all good. And the team, by the way, was so traumatized. He also is my favorite because he came to the ICU later and was like, "Jody, I am so sorry. Like, we did not have that was going to go." And I said, "Look, I'm safe, baby safe. Thank you. Gold star all around. We're good." 3 months later, I'm there again, right? With baby number 2. But here's the thing. My doctor, my medical team gets massive credit. All the same people were in that room, despite the fact that they had like less than a few hours because I became unstable and we had to do it emergently. So everyone in that room knew what to do and knew what was going to happen. So guess what? That meant I could dissociate because we didn't need that.
Yeah.
It's so different. And I was so much more calm and in myself because I could be like, whatever, y'all do your thing. Yeah. That my husband afterward was like, "So great, they could use anesthesia this time." I was like, no, they didn't. But I could use those dissociative skills because I knew I was safe and the baby was safe.
Right.
And that permission.
Brain's opinion of how safe you are.
Yeah. So it's totally different and that's when we talk about with even procedures, even the simple blood stick and the use of that. This is to keep you in healthy and safe. This isn't dangerous, so you don't need to pay attention to it.
Yeah.
And that you don't need to pay attention to it is a permission to let go of that hyper.
I love that. I am so going to use that. My current grant is looking at how to the interplay of different frequencies with multiple motors so that you can trigger and focus the pain blocking where you need it. And right now, the one we have is an opioid reduction thing for low back pain. And so it's like, it's got an array, and then it's got a place for hot or cold. But right now we're actually waiting to hear back on a grant for pelvic pain. And I wonder if, I don't know how many people are in your situation, but I wonder how much putting this around for the front and having the different frequencies to block the pain signal from labor pain or even from C-section pain. Yeah. I wonder if that's a potential use for it, because
I love to tell me the stories about how like the epidural failed in the middle, whatever of that. But even that thought, and again, the psychological benefit of just backup, right?
Yeah, exactly. Just knowing you can tolerate pain longer if you know you have something to fix it in the other room. You can be like, okay, I can wait 20 minutes. Well,
yeah.
What? All right. So what's one of the funniest stories that has happened to you in either for yourself or in taking care of a kid who has that you're helping with pain management?
Well, one of my favorites. So so it's amazing. So when we were teaching, I was a postdoc actually at Children's Hospital Orange County, which was amazing. And I worked with this amazing woman. We were in the hematology clinic and where kids got infusions and a lot of blood work happening, but a lot of infusions that weren't necessarily expected. So there was a lot of kind of like anxiety around, hey, we're having a bleed or we're having something happen. So there was already kind of a, increasing the anxiety, and now we have to have a needle and there's that. And I had a little boy who, one of the phrases we also use, I'm all about the use of language, is to blow away the bother. So when we're doing so using that term bother, because it really does bother us to get a needle more than it, hurts, right? And so we talk about blowing away the bother, and he was doing this, and he happened to be having a lollipop at this time that he was chewing on, and they, carefully cleaned it, and as one does, and they were in the middle of this, and he's putting it in, and we're talking about blowing away the bother, and he's using his strategies, and he decides that that's not enough, and so he turns around and blows on the needle, and blows like lollipop and sugar spit all over. He's like, I needed to blow away the bother because that's where the bother was. And I'm like,
seems legit.
Solid point. Excellent. Excellent point. And similarly, it's just the kids are the cutest. The little girl was about 5, and we were doing some self-hypnosis techniques of, breathing in color and breathing them out. And she had to go. We're literally like, I'm following her because she ended up needing to have kind of some imaging, and her mom happened to be like the 1 hour of the day. Her mom was gone, of course, and she had to go. And so I'm, they're like, Jody, can you come? So we're in the hallway, and I'm just talking her through breathing in comfort and breathing out the worry and breathing out the stress and breathing in comfort. And it was green. And right before she went in the procedure room, she looks at me and she goes, do you think they're going to be able to see the green on my x-ray? Because she filled herself up with her green. So kids are just the best.
I'm giving you a humor.
Hey, look, I get it all. I'm so excited.
Sometimes they're the best, but when I did procedural sedation,
mm-hmm.
So I was always trying to get the kids through sedation without actually sedating them, trying to, whether it was bribery or whether it was, telling them what things to think about, but just, the goal was to give them tools so that we didn't need to put them to sleep. But I was there and put them to sleep if they need to, because that's fun. But this one day, they brought the older brother in, and she said, I think I can do it if he comes with me. And it's like, well, he can't stay, but you can let him come in. So anyway, so you've got to stay really still on the MRI and get studied. And so the little brother came in and kind of leaned down next to her and spoke into her ear right before she went in. And she was amazing. She was still the whole time. So we're like, wow, this brother just so encouraging, such great, wonderful support. And, so we loaded him up with toys and stuff also. So anyway, so she comes out of the MR and she looks terrified. She is petrified. She's got tears running down her eyes, but she's not moving. And we're like, honey, you're done. What's wrong? And she said, will my head still explode if I move?
So I'm sure she's still in therapy years later.
Rat of a brother. Rat.
So maybe not that whole assuring her of her safety thing.
Apparently not. All right. So last question, and then got time for anything you want to say or any questions you have for me. And I'm not going to hold you up. I'm going to let you know right now, you've been awesome. And you get the full honor roll.
Yes.
All right. Yes. So, and this is a hard question. I should have let you have it before, have time to think about it. But what is something that you taught people about pain and believed that you no longer believe?
I don't. This is a really hard one. You're right.
It is, and I'll give you a couple.
Like, what have you done? Like, I'm trying to.
Well, and certainly I can say one of mine. And I've got a number of them.
Yeah.
But one of mine is that when I was trained on pain management, I did a lot of lectures talking about staying ahead of pain, and particularly opioids. I mean, I was trained during the Purdue Pharma Sackler time, and you're pretty vulnerable when you're exhausted and in post call, and they feed you lasagna in a dark room, and you're like, okay, yeah, they wouldn't let this person talk to me unless this is true. Seems legit. So I'm absolutely a big opioid fan if you're in the hospital, but I do believe that 15% of people are genetically predisposed to be fast metabolizers and get addicted regardless of anything. And so I believe that, and I also believe that for everyone, stretching out and delaying the amount of time between opioid doses is always going to be better than using an opioid to stay ahead of the pain. So I think not getting overwhelmed by it is still very true, but I would no longer schedule opioids as an outpatient for almost anything. So
yeah, so I get the, of course, perk of not being the physician. So no one wanted to hear my opinion on medication. And I think I think that's been one of the more transformative things over the course of my career. I mean, I remember, ketamine, of course, is such a thing where kind of where I'm at right now. And I distinctly remember sitting in a meeting when I first started the chronic pain program at Stanford, and our director, who's amazing and great and good, was like talking family. He was like, they're in Germany, they're doing something with ketamine, and what do you know? And we're like, no, there's nothing good about ketamine, and that's terrible. And which did reflect the data at that point, right? Like it reflected. And so that's it. I think both of those things are such, and again, I got the perk of doing stuff that we've been doing forever, just that's underutilized. So I get to play my psychologist hat. But I also think it's such a beautiful thing at the need to keep ourselves open. And I think that's one of the challenges within the medical community in general over the acceptance of things, is that we have to kind of constantly question ourselves and constantly question, is this good? Is this not good? What is it saying? What are we seeing? What is the data in front of us? Whether that's from an individual person, as we're talking about that with autism this morning, kids who underreact and overreact to pain stimuli, and the need for parents to be an advocate because they're the expert, right? I'm like, look, you're going to know what is normal and not normal for your child much better than anyone who's ever going to interact with you in the medical care system. And we need to use that because they're not going to fall into what it should be like, which is a phrase I would love to strike from everyone's lips. Well, this shouldn't hurt. I'm like, so nice of you to decide that for everyone. I'm like, well, you shouldn't say things like this. And we're both.
Yeah, Ken's a great example of how things change and how we do need to be open to new learning. It's, the two human characteristics are, once you've thought about something and made your mind up, there's a reluctance to waste that mental energy again. And the other thing is that the cognitive dissonance of, this is how I've always done it. If I learn that I have been inflicting trauma, hurting people, and even not doing it as well as possible, then I have to contend with feeling like I've been wrong and doing it badly. And those two things are really hard to get humans to move back from, especially if you're a human in a position of authority.
Do you know the story? One of the best, I give this example a lot too. Do you know the story of X-rays in pregnant women?
I don't believe I do. And we've got on our hour, but tell me the story.
So the quick version is that, so it was in the 1950s that we started seeing this rising cases of leukemia in children. Oh. And so there was this very large epidemiological study done by this amazing woman whose name escaped me right now. She feels terrible, so I'll email you later. And she, of course, a female doctor in the 50s, not winning popularity contests. And so she was doing this massive study and looked at every factor possible, the cereal they ate, what time they went to bed, everything. And because the interesting part about the childhood cancer at that point in time is it was unlike any other disease practically. It was happening among higher socioeconomic status women. These were not kids who were on the lower SES of things. And what she discovered was that this was because doctors had their fun, new, cool tool of an X-ray and were looking at the pregnant women. Turns out causes cancer in kids. Now,
cancer when they had the shoe places that would do X-rays of whether the shoe fit.
Yes, and she published this data, got death threats, got kicked out of all the major medical societies. And so, you know, when did we stop actually x-raying pregnant women? Not until the 70s. We literally gave kids cancer for like 20 years.
Yeah.
Because it was so difficult. And why? Again, it's a very human thing, because if you sat there and truly accepted that data, then these physicians who wanted to do no harm, who were doing their best, had to come to terms with the fact that something they had done caused childhood cancer.
Well, I really think, you know, to bring it home to needle fear, I really think that's why we're not seeing our leaders change how we give those 4 to 6 year shots. I think it's because if we acknowledge that we're causing a lot of adult non-compliance, we're causing trauma, we're causing people to not get healthcare, then you've got to acknowledge that you were wrong. And even though, you know, and I understand that it could cause confusion, and that the messaging of no, that maybe it'll be easier after the pandemic, saying no, you know, 2, 4, 6 month shots, those are absolutely the right timing, and 2-year shots, 12-year shots, those are the right timing. But the boosters were a little more wibbly wobbly, timey wimey, loosey goosey on. Maybe we can get that message across more easily now. But I really think that part of why I've had, and we've had so much trouble convincing people to be able to not traumatize somebody by overwhelming them is because the people in charge don't want to have to acknowledge that they made a mistake.
Yeah. And which is a very human thing, and I think just calls for that need that we all need more of these days in general. It's just empathy and kindness and compassion for each other. And
humility. And I do think that truth corrodes bias eventually.
Yes.
But the fact that it has to corrode rather than gently nudge aside is
keep up the battle. Yes.
Jody, you have been amazing. And I'm going to tell you something. The last thing I'm going to show you is that you are the absolutely first recipient of our Pain Care Labs cutting board.
that's much fun. And we actually use. Yeah.
We just put it around to opioid reduction and pain management, but this is going to be for you. And I will mail this and your Buzzy Bravery Honorable.
Yeah, that's going up on the wall.
Thank you so much for this. And we will have this as a podcast and our YouTube and, you know, the whole like, subscribe, 9 yards thing. But where will we see you next on TV?
Let's see. I did an interview this morning with CBS in Charlotte and another one in CBS in California. And we'll be, and I think there'll be a few more coming up. We have an HHS, the Health and Human Services Trusted Messenger video that'll be coming out talking about how to protect kids. So, and whatever else keeps on coming our way. So,
awesome. Well, you are magnificent. I am so grateful to you. Thank you so much for coming on.
Thank you for building your products and keeping up the good fight.
You know, it's gonna be fine.
It is.
Thank you again.
Thank you so much.
Bye-bye.